Hi, everyone, and welcome to the Muslim Sex Podcast. Thank you so much for tuning in. I really appreciate your patronage, and I would love it if you could leave me a 5-star review because that really helps me. And if you could like and share this episode with somebody that you know that may benefit, your friend, your colleague, anyone, I'd really love you to share this podcast, especially if you find value in the Muslim Sex Podcast. Also, I'd love for you to subscribe to my YouTube channel and follow me on all my social media. Also, as you probably know, if you've been listening to this podcast, is that I have a practice that is now open in Chappaqua, New York. I see patients for menopause and sexual health, as well as regular gynecology. So if you are looking for a gynecologist that actually spends time with you, that has time to listen to you, then I would invite you to come and see me in my practice, and I'd be more than happy to take care of you. So make sure if you live in the New York area, or even if you don't, come and see me in my office. I'd love to meet you. And also, last but not least, is that I am hosting again my retreat in Morocco for 2025. So if you are looking for a gift for a family member, a friend, yourself, make sure you take a look at our retreat, the Love and Nourish Retreat. It will be held September 19th through the 26th, 2025. Again, this year in Morocco, we will be visiting the same towns. We will be in Marrakesh and Essaouira. And as always, we will be providing information and lectures on menopause, perimenopause, nutrition, and also going for cooking classes as well as excursions. So don't miss out. I know a lot of people were sad when they missed out this past year on the Morocco retreat. So make sure that you go and visit the Love and Nourish Retreat hosted by Caria Retreats. And now onto the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about menopause. Before I get into it, first thing I want to make very clear, this is not any type of medical advice. If you have any questions about your health, please speak with your healthcare provider. And definitely, this is no advice on religion. So if you have any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am super excited to have with me Dr. Louise Newson coming to us all the way from London, England. Thank you so much, Dr. Newsom, for coming on. I really appreciate your time. I know you are super busy.
Oh, thanks for inviting me. It's great to be here.
So I'd love to get into, for those that do not know you, which I know would be hard to believe, but for those that do not, if you could please just introduce yourself and let them know, the audience, what you do.
Yeah, for sure. So I'm Dr. Louise Newson, as you say. I'm a GP, so a general practitioner, family physician, but also a menopause specialist. So I've got a lot of knowledge and experience in hospital medicine, as well as being a GP for 25 years. But I'm also been a medical writer as well. So I run a very large clinic in the UK, but I've also created the free Balance app. And I do a weekly podcast myself as well, and do a lot of education for healthcare professionals as well as for women.
Amazing. So I know that you have been actually all over the world recently. You were in Australia, and I believe you were also in Singapore. Can you tell us a little bit about that?
Yeah, so menopause is a global problem. Hormonal health is a global problem. Most women are not receiving evidence-based treatment. So a lot of my work is globally to educate as many women as possible. So I went to Singapore and did some events for healthcare professionals and also for women, and then went to Sydney, Perth, and Melbourne, which was great. Met all sorts of inspirational doctors. The best part really was doing a presentation at the Sydney Opera House, which is everybody's dream, really, isn't it? To perform there to a packed audience of 2,500 people was very incredible, with three great colleagues in America who were with me. But I also did a lot of education for healthcare professionals, so nurses and doctors as well. which was wonderful, but also sad because it makes me realize that, in every country there are women who are really struggling to be listened to and believed and understood.
Yes, absolutely, absolutely. So you yourself have quite a few clinics in London and England, and I believe you see about 4,500 patients. Is it a day, monthly? I know you
And
see
we
quite.
see about sort of between 2 and 3,000 women a month through the clinic. The clinic I set up 6 years ago with a friend and colleague, Rebecca Lewis, and we just thought we would have a few doctors working with us, and it became very busy, very apparent that a lot of women are really struggling to be seen and managed appropriately. So people come to us from all over the UK and often tell us stories of why they've been given antidepressants inappropriately and the symptoms haven't been addressed, which is really sad actually, because as we know, menopause lasts forever. The low hormones not only causes symptoms but health risks as well.
Absolutely. So I know that, here in the US, a lot of the residents and the medical training does not really focus on menopause, perimenopause. And because of the WHI study that came out in 2002, a lot of the residents here were not trained. I'm not quite sure how it is over in England.
Sadly, it's not much better. A lot of people have had suboptimal training about menopause and perimenopause. And so a lot of people, like you say, are still scared of hormone replacement therapy because of this study, the Women's Health Initiative WHI study, which actually was giving the wrong type of hormones to the wrong type of person at the wrong time and age as well. But actually, the results were misinterpreted. And actually, if you look at the evidence, even from that study, it shows that women's um, they did improve actually. Their symptoms improved, their bone health improved. They had a reduction risk of bowel cancer, for example. The breast cancer risk wasn't there with the estrogen only people. They actually had a lower incidence of breast cancer, and it was with a synthetic hormone. There was a small increased risk, but it wasn't even statistically significant. So nearly 25 years on, people are still scared about breast cancer and hormones, and actually we don't have evidence. We don't have good quality evidence that women taking HRT have an increased risk of breast cancer. But we do know that if women are not taking HRT, they have an increased risk of heart disease, osteoporosis, diabetes, dementia. And this is really important because we're living as women so much longer.
Yeah, absolutely. And there's so many health risks for women not taking hormone replacement therapy. So
Mm.
I know that in your clinic, there was an article that came out about different doses. And, you had, I think you had mentioned in that article that different women absorb estrogen differently and through different means. And, what works for one woman may not work for other women. Can you talk a little bit about that?
Yeah, for sure. We're very fortunate now that we have natural hormones. So the biochemically, the structure is exactly the same as the hormones we produce when we're younger. And when I talk about hormones, all they are chemical messages that go to every cell in our body. But the hormones are estradiol, which is a good form of estrogen, progesterone, and testosterone. And we usually give them individually, so you can really tailor the right dose and the right type and the right combination for each woman. But the estradiol and the testosterone go through the skin. Now, the skin is a barrier, like we put on our moisturizer or sun cream and we don't want it absorbed into our bloodstream. There's very few things we can put through our skin as medicines, but estradiol and testosterone are two hormones that do penetrate the skin. But the absorption really varies. And we've known this for decades. We've known it for many years. There's a study in the 80s showing that hormones metabolically and the way they absorb differ with different women. And we see this a lot in our clinic. And even for me as a menopausal woman, I don't absorb very well through my skin. So I use a higher dose to get an adequate amount through the skin. And so we've written up our data and had it published in a peer reviewed journal showing that about a quarter of our patients need higher doses to have adequate absorption through the skin. So, and that's really important because we know, and it's been known for many years, that if people have low estradiol in their body, they've still got inflammation, they've still got this risk of future diseases. So the reason we give hormones is to improve symptoms, of course, but also to improve future health. So there are risks of not having enough treatment, really. And that's the same with testosterone. There are different formulations. So some people absorb one type of formulation, like the gel, better than the cream, or vice versa, because we are all different. And the problem is with so much of not just menopause care, but women's health in general, that everyone's treated the same. And we're going to have different responses to different treatments, of course.
Right, absolutely. And you're so right. And that's why it's so important to go to a practitioner that knows that, right? Not all practitioners. Well,
Mm,
I think that not all practitioners know very much about menopause to start with. And then they assume that everyone should be absorbing exactly the same amount with the same dosage. And that's not the case. And I think that really your research in proving that was so important because,
mm.
that is really important to know whether or not, when women come to us and say, well, you put me on this dose of estrogen and I'm still having all the symptoms or I'm still not feeling well, we have to really look deeper into that and see whether or not they are absorbing. So when you go and, talk and speak throughout the world, what are the most common things that women come to you and tell you about, perhaps their symptoms or what they're feeling? What happens?
So, so the most common symptoms actually that women are experiencing, not just in the UK but globally as well, are symptoms often affecting their brain. So, low mood, anxiety, reduced concentration, fatigue, poor memory, irritability, and a lot of people are misdiagnosed with depression. The other symptoms that's very common are musculoskeletal symptoms, so joint pain, muscle aches. They can often be worse in the morning, but often people are misdiagnosed with a type of arthritis or a fibromyalgia, for example. And then also urinary symptoms are very common. Reduced libido can be very common, and localized symptoms, symptoms of vaginal soreness, discomfort, pain. And a lot of people are too embarrassed to talk about those to their healthcare practitioner as well, or if they have, they've been dismissed. And the problem is in medicine, often we're very siloed. So if you go and see a heart specialist and talk about your palpitations, they won't think to ask you about your brain symptoms or your joint symptoms. Or if you go to a urologist about your urinary tract symptoms, they won't think to ask about any other symptoms you have. And so that's why it's so important for women to have the knowledge. But what I am finding globally as well is that women often have more knowledge than healthcare practitioners,
Yeah.
which is good and bad. It's really great that women are empowered with knowledge, but it's really sad because they decide themselves that they want to try an evidence-based treatment in the form of hormones, yet they're being turned away. And every day we hear people in the clinic who've been told no, their doctor just won't allow them to have hormones, which it's 2025. Like, I don't understand why we're not allowed to try something that will actually help us feel better and likely improve our future health as well.
Right, absolutely. I saw that actually in The Guardian, right? It was earlier this year that they had published about vaginal dryness and how that woman in that article had has switched 4 jobs, had quit 4 jobs in 4 years. And, she never was able to get any help. And finally, she received help. And I think that that's so true that, sometimes women will bring up that they're having hot flashes and night sweats and all of those muscle aches and joint pains, but sometimes they'll just be too embarrassed to bring up the fact that they're having this vaginal irritation, chronic UTIs, overactive bladder, pain with sex. And a lot of women actually feel that, and they've been told that, as they hit menopause, that they don't need to have sex anymore and that, that part of their life is basically over. Have you seen that in your clinics?
Yeah, for sure. I obviously, as a doctor, I can talk about anything, including sex, or lack of sex. And a lot of people don't talk about it, and they're really quite relieved that it comes up in conversation. But it's really, really sad that people don't know who to talk to,
Right.
and then they're just being told, "Oh, it's just because you're older." Like, one of my patients went to go and see one of her doctors for some more hormones. She's been taking hormones for a while, and she's really well. And the doctor said to her, "Look, you've just had a divorce, so you don't need your testosterone because you're not going to be having sex."
Oh my
It's like,
god.
hang on, like, this is just in so many levels wrong,
Yeah.
And I feel like it's really degrading for women. Like men can buy Viagra over the counter. No one asks them about whether they're having sex or who they're having sex with,
Right.
or indeed what their libido is like. It's like it's fine for men, but somehow for women, it's almost embarrassing if we have to ask if we can, you know, have sex that's not painful, or if we can have an orgasm that's pleasurable. Like, why is it so awful for women to want to have sexual pleasures, and why do we don't always need men to have those either? It's like
That's
it's
right.
it's really, I think it's just awful that women, even some studies have shown that when women do try and get help from their doctor, they often get dismissed, or the doctors are embarrassed, or they don't know how to give help, so they sort of avert and try and talk about something else. And I think this is really sad because women don't know who to turn to. And a lot of women I speak to have stopped having any sexual relationship. But if they do have sex, they tell me it's so painful, it's so uncomfortable,
Yeah.
it's so sore, but they're too scared to tell their partner.
Yes.
And that's so, under so many levels, is wrong. How does that partner feel? And if they don't feel awful that they're hurting their partner, then that's wrong as well. But they often then don't know who to talk to, and it's so easy to treat as well. That's the other thing. Vaginal hormones are very safe, very effective. They can be used by women who've had breast cancer. Yet we know only the minority of women with symptoms are receiving those treatments.
Right, absolutely. And it's so hard to, actually not explain, but convince women that they're safe. I think that oftentimes
Mm,
we come across this. In fact, I just encountered a woman yesterday in the clinic that told me that she's actually only 50 years old. She had a hysterectomy, so she had a total abdominal hysterectomy, her ovaries removed, and a bilateral mastectomy after she was found out that she had a positive BRCA gene. But nobody talked to her about hormones. Nobody offered her vaginal estrogen. Nobody
mm,
gave her any counseling, and she's a mess, and she
yeah,
comes in and
yeah,
she's having all these symptoms, and she's like, nobody's talked to me about anything. And she never had ovarian cancer. She never had breast cancer. It was just that she was positive for a gene. And so she had all that
yeah.
surgery done.
And it's so sad because these people's lives are falling apart. And I spoke to someone yesterday, actually. She's a doctor from Ireland, and she's had breast cancer. She's had bilateral mastectomy, so both her breasts have been surgically removed. And she was on hormones, and she really misses them, and she worries about her future health, especially her bones. And she said, there's no one that I can talk to just to have a sensible conversation about the risks and benefits of having hormones, including vaginal hormones as well. And, a lot of people just want to be spoken to. They want to have a choice. They don't want to be judged, and they don't want to be treated the same as everybody else. And I think as a doctor, it's such a privilege to give people individualized conversations and consultations, and actually listen to things that they probably haven't shared before. And, as you know, different patients have different concerns, they have different worries, they can take different risks. Some people buy sports cars and some people don't. Some people go horse riding, some people don't. Like, it's fine. But
Mhm.
somehow when it's choices about your health, it's almost like the doctor has said you can't have or you can't do, therefore it's not an option for you ever. And we see people who've had breast cancer 20 years ago, and they're having recurrent urinary tract infections in and out of hospital, and no one's even thought about some vaginal hormones or even put the connection together. And I just feel the suffering is palpable, which is such a shame.
Yeah. Yeah, absolutely. Absolutely. So you and Sarah Glenn have published quite a few articles and
Mm.
research. And so, what are the upcoming research that you're working on?
Well, lots actually. We're very fortunate because we've got a big database of our patients, and I feel very strongly that we should be externally sharing it with people. So, when I was in Perth in Australia, I presented some data about urinary symptoms, how they improve with testosterone added into HRT, and prasterone, which is DHEA. It's a vaginal pessary that forms estrogen and testosterone. So we presented that data. We've also just writing up our data looking at women who bleed on HRT, whether they have a risk of cancer of the lining of the womb or any abnormalities. And the data is very reassuring, you'll be pleased to know. But this is great because no one else is writing up data like this. we're also got a study looking at a bit more in more detail about testosterone and also about sleep as well. And then
Mm.
we're doing a lot of work looking at de-prescribing, which sounds a bit weird coming from a doctor who prescribes, but actually I really like stopping antidepressants and painkillers and sleeping tablets. So we know that a lot of women, when they're on hormones, they don't need those other medications. So we're looking at the de-prescribing data, which is really interesting and reassuring. And then I fund a PhD student in suicide prevention at Liverpool John Moores University. So we're looking at our data, qualitative and quantitative, about suicidal thoughts and how they can change when people have hormones as well. So there's quite a lot going on.
Yes, there is. That's fantastic. That is really amazing research, and it's so needed because we know that
Mm.
for women, especially, right, that there is not much funding for research, and there are not that many people that are publishing research. So this is fantastic. So I'd love to know more about. Have you published any more recent books?
So my last book came out last year.
Mhm.
So that's my fourth book on menopause, and I'm just sort of thinking about the next one actually, because increasingly my work is more about hormonal health. So not just menopause or perimenopause. A lot of women we see with PMS, premenstrual syndrome, PMDD, premenstrual dysphoric disorder. And again, it's a hormonal change, it's a hormonal issue, and it's not being addressed properly. So, the more I understand about hormones and the way they work biologically in the body, the more I feel like I want to share my knowledge.
Yeah.
And also about the difference between natural hormones and synthetic hormones, including contraception, because they work very differently in the body. And as a doctor, I didn't really think about it for 30 years. So I feel like I should be sharing what I know so women again can make choices about contraception, about their hormonal health as well.
Yes, I think that's really important what you bring up about synthetic and those hormones that are more bioidentical. Maybe you could elaborate on that.
Yeah, so I mean, when we talk about estrogen, progesterone, testosterone, they have a certain chemical structure. They're very similar, but they're slightly different. And they all work on the receptors on cells specifically, and they have very good predetermined actions and functions to keep our cells and our tissues and our organs healthy. Now, if they've been chemically structured, if they've been chemically altered, the structure changes. So it's just not going to fit on the receptor the same way. It's not going to have the same biological effects. And some hormones have been altered more than others. And so estrogen can be altered differently, progesterone can be, and even testosterone too. And they then have risks and side effects, and not going to have the same benefits to hormones as the natural hormones. So often people call them body identical hormones or bioidentical hormones, and it just means they look the same, so they have the same structure. Whereas often people just talk about estrogen or progesterone and they're not being specific. And it is important because they work differently in the body. And there's quite a few women who say, no, I had side effects on the contraception. I don't want ever to have hormones. But then they're going to have a different effect to the natural hormones. And so it's important that we understand the difference when we're prescribing, but also that women understand there's a difference to their bodies as well.
Right. And you're absolutely right. The different hormones, especially synthetic and bioidentical, act differently in the body. And it's really important for women to know what happens when you take birth control and how that can affect not only your libido, but also it can sometimes cause pain in women when they start to have intercourse. And there's
Mm-hmm.
also although the research is not quite there, but I was talking to Dr. Jill Kraft, and she was talking about, depending on when girls and women start oral contraceptives, and we know that oral contraceptives are made with synthetic hormones, that some women can later on develop this neuroproliferative, what we call vestibulodynia, pain with intercourse. And if they start younger, less than the age of 17, they have a higher risk of developing this neuroproliferative. Whereas if they start after the age of 17, and they think it's because those receptors are still, they're still building and they're still learning the hormones. And so that's why some women develop it and other women don't. There's actually, I believe, a relative risk of like 9 if they start less than the age of 17, as opposed to if they start earlier. So really interesting. And especially when you talk about synthetic and more bioidentical hormones, is there some research on whether one works better than the other? I know that some women, for example, when they continue to bleed, right, on hormones, it will
Mm.
change the progestin so that they stop bleeding. Is there any research on what works better, what doesn't, or is it just based on, the woman?
Yeah, everyone's different. I mean, when you look at the data actually for synthetic hormones, a lot of it has been done on bleeding, whether the womb bleeds or not. Actually, what women want more data on is whether their brain works or not, because we're more than just our womb. Um, but we know that people vary, and often actually in the clinic, if people have a lot of bleeding, I used to give synthetic progestogens, but I try to avoid them now actually, and often I give progesterone as a vaginal pessary, and that can be really beneficial because you can just have a higher concentration of the natural progesterone where it's needed in the womb, and that can make a real difference to women. Picking up on your comment about vestibulitis or vestibulodynia, and that pain that can occur with contraception, some of it is because testosterone's been blocked. So
Mm-hmm.
the natural
Yes.
hormones, so if people have birth control, it increases something called your sex hormone binding globulin and reduces the freely available testosterone.
Yeah.
And we know we've got androgen, i.e., testosterone receptors, all around the vulva, vagina, clitoris, the perineum. And so, if testosterone isn't able to work because it's been blocked by these synthetic hormones, that will increase pain, discomfort, and increasingly, I see young women who have testosterone deficiency who are
Mm.
on contraception, giving them back testosterone, giving them pessaries that convert to testosterone, will melt away their vulvodynia, which I sort of look back at my clinical practice over the last 30 years and think of the women I've seen before, and I didn't know that we had testosterone receptors. We give them local anesthetics, we give them like tablets like amitriptyline to reduce the pain, but that's not treating the underlying
Right.
cause. So that's where the more knowledge that every doctor that sees women has about hormones, the better it's going to be for women going forwards.
Absolutely, absolutely, and you're so right. And I think the other issue that we have is that not only do physicians not get trained on menopause and perimenopause and treatments, but also on sexual health. We just don't get those lectures, and so you
Exactly.
actually have to seek out those lectures, seek out those organizations that teach on sexual health. Here in the U.S., we have the International Society for the Study of Women's Sexual Health, ISWISH. I know
Mm.
in Europe there's ISM as well, ISSM. I actually just had Dr. Emmanuel Giannini from ISM on this podcast as well this past week. So he was talking a lot about the research and work that he's doing as well. But you're absolutely right. I mean, when we don't know, right? I mean, we can't treat somebody properly if we don't have that information. But it's also being humble enough to know that you don't know, and so then you go and you
Yeah.
research and you look it up and you learn so that you can
Mm.
help women. I know that in midlife, we see a lot of distress regarding hypoactive sexual desire disorder or low desire. Do you notice that? Do you see that in your clinic as well?
Yeah, for sure. I mean, I have a bit of an issue with the diagnosis of HSDD, hyperactive sexual desire disorder, because if you look at the criterion, one of the criteria is that women have to be severely psychologically distressed with their reduced libido for
At
at
least
least
6 months.
6 months.
Hmm.
And I just, as a doctor, I don't want anyone to be severely psychologically distressed with any symptom for any time, let alone waiting for 6 months. But reduced libido is so, so common. And when we look at what libido means, it's not just sexual desire, it's actually just joy as well. And I think this is where we have to have better understanding, and we do have the knowledge about how the hormones work throughout our brain. And for some reason, when we talk about HSDD and testosterone, people think that's the only way that testosterone is ever going to help is with women with HSDD. So wait for them to be really, really distressed, and then give them back some of their natural hormone that works throughout the whole brain, throughout every single cell, in every tissue and every organ of the body. Like, it doesn't make sense. But we know a lot of people have reduced libido, and some of it is because they feel so awful. They have low mood, they're irritable, they've put on weight, they've got muscle and joint pain. They are not going to feel like having any sort of sexual relationship with anybody. Sometimes it is only the libido and no other symptoms. And sometimes it can be due to other things, not just hormones as well. And so, obviously, in medicine, taking a good history is the most important thing. But often, when we rebalance hormones, people feel happier, they feel more joyful, they have more energy, they sleep better, they feel better in themselves. And that, of course, is going to help with libido. The problem is a lot of the studies, as you know, have only been focusing on HSDD, and any other symptom improvement is a second endpoint. It's not something that's the main aim of the study. So data gets skewed, it gets misinterpreted. But day to day, we look at real world data as well. We look at patients' experiences as well in the right context. So we know our hormones work throughout our body. We know they have all these effects, and we see before our eyes that people improve. And often in medicine, it's multifactorial. It's not just giving the hormones. Once people then have hormones and feel better, they often think about their nutrition and they eat better. They often start exercising because they've got more energy and less muscle and joint pain. And exercising has a very beneficial effect for us. They're often sleeping better. They're often happier. So their relationships with others, just their friends, going out, socializing, their mental health improves. So that's piecing everything together is so important for our patients.
Right, absolutely. And what you mentioned, the whole biopsychosocial aspect, right? Just taking a look
Mm,
at all the different aspects of a person and how it's being affected by their decreased libido. And I think that, just what you say, I mean, it's not just about giving hormones, and hormones are so important, but it's not just about that, but it's about addressing and looking at the other things that could be influencing their low
mm,
desire. Are they a single mom working multiple jobs that they just don't have the
mm.
energy, right? And is that just one more thing on their list of things to do? Are they, do they grow up with sex negativity? And so it's really hard for them to have any type of desire or think that that's okay to have desire. And, there's so many different aspects of that. So I definitely feel that when when a patient comes in and mentions that they have decreased desire, it's not just like a 5-minute conversation. There's so many different aspects of it. And you're absolutely right. I mean, hormones play a significant role, but there's so many other things to it as well. I'd love to know, just as we start to wind down this podcast, but I'd love to know your thoughts on if you were to give somebody, like key pearls on menopause or something that they should take away from this podcast and go and think about and perhaps read about. What are some key things, takeaways that you think they should know?
I think the first thing is to remember that everyone's individual and we can make choices that are right for us. They might not be right for our doctor, they might not be right for our best friend, but they have to be right for us. So I think prioritizing your own health is the most important thing that you could probably do as an individual, and making choices that are right for you. Knowing that any choices you make, you can change your mind. You're allowed to do that in medicine and anything else that you do. But also reminding yourself that menopause lasts forever. So
Yes.
once those hormones are down, they are down forever. You might have a
Yes.
tiny bit of estradiol in your little big, little toe or something, but they will be low forever. And
Yes.
so whether people have symptoms or not, there are health risks of not having hormones.
Yes.
And so it's really important that you're not making a decision on how you're necessarily feeling today, but it's thinking about your future health.
Yes.
And if you're going to hopefully live decades or even years or even months, it's got to be the best time of your life because we only get one life. So looking at how you're going to spend your time with being menopausal or perimenopausal, what you're going to do and how you're going to achieve that is really important. So having knowledge from people who, don't have biases, that don't have conflicts, that are evidence based is really crucially important.
Yeah. Yeah. I love what you said right now because I think that so many women that I talk to think that menopause, they're like, oh, I'm done with that. Oh, I
Mm,
had hot flashes. I'm done. Now I'm fine. I'm like, no, that lasts
mm,
forever. You are in
yeah,
postmenopause until you die. It's not just
mm,
like one time, you're done. Oh, I had hot flashes. Now I'm through that and now I'm fine. It's I'm like, it's not about that. It's about the rest of your life, and I think that that's so important that you bring that up. And I'm so glad you do. And, at the recent conference that I just attended, Ishwich, one of the lecturers said something, and I thought it was so, so important. And he stated that, it's not about adding years to your life, but it's about adding life to your years.
Yeah, for
And I
sure.
thought that is exactly what hormones do, right? They add life to your years, because it's not just about, going through and just living out whatever our days are, but it's about, living our best lives and being functional and having that cognitive ability, and protecting our heart and decreasing our inflammation and protecting our joints and all of those things. So it's not just one thing. So I appreciate you saying that. And I think those are so important, those takeaways. For those people that would love to hear more from you and would love to follow you, what are some ways that they may do that?
So the easiest way is to just go to my website, which is Dr. Louise Newson, as in Dr. louisenewson.co.uk. You can follow me on Instagram, menopause_doctor. Download Balance, a free app, lots of information on there. And my podcast, my weekly podcast, is just called Dr. Louise Newson. So there's lots of ways to access information and, join a community and amplify our voices, which is great.
Absolutely. And all your books, all the books that you've written, right?
Mm, yes, yeah.
You forgot all that work that you did and all the research that you published. So, well, thank you so much for your time and your tireless advocacy work that you do to help women learn, and you educate them about menopause. So, thank you for all that you do. We really appreciate the work that you do. So, thank you for being out there,
Oh,
and thank you for
thank
being the
you.
voice of women. We appreciate that. So,
Oh, well, thank you. And thanks for inviting me onto your podcast. It's been
oh,
great.
welcome. So, well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're having issues with menopause, perimenopause, low libido, any of those things, please speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.